So LA closure starts with good puncture. You know that you can go posterior superior, posterior anterior, depending on what you are doing on the left side. And it's like this. Sahiwal prefers single curve. We prefer double curve. But once you are inside the LA or in the left atrium, doesn't matter whether you're using single curve or double curve. And you know, these are the locations of your mitral clip. Or so now there is a tutorial available in CRM
to give kind of ground us in the anatomy, so that as we go to the lab and other imaging modalities, we'll have a sense.
Again once more. So you need to understand that you have to puncture this, and there are different types of fossa ovalis. You need not puncture the PO4 because PO4 is a tunnel. You cannot manipulate the sheath nicely in the PO4. So if you have a hole in the septum, it's much easier to penetrate and much easier to handle or reach the LA appendage, which is anterior. You go posterior for your safety, and you go inferior for your entry, but you have to go superior, as Gopal is doing a lot of mitral clip in India or TM here, they go superior. So all depends on your what you are doing, the clip or your this mitral valve leaks or any other thing. So anatomy is very important. Nowadays we are doing some CT scan to assess. Now there are new data available, and NCDR registry is one of them. And it tells that it reduces ischemic stroke. And we know that the stroke due to LA, that the breakthrough strokes are much less in severity and disability than your strokes on your NOAC or warfarin. So warfarin is the worst. Next worst thing is NOAC. The best thing is LA closure. And if you go epicardial, there's reduction of ischemic stroke. If you go endocardial closure, we still do not know by randomized clinical trial, but the number of strokes definitely decreases if you consider both hemorrhagic and non-hemorrhagic strokes. So there is no doubt that in future, this may move from 2B to 2A. Still, you have to have a lot of trial to move it to class 1 therapy. So that is new, and there are a lot of newer data, newer devices. Recently, the Omega device, which is available in European market, is different from your Lambre. So India, we have Lambre, we have Watchpen, and we have Amulet now. So newer devices are much more safer. The chance of dislodgement or embolism is much less, and different type of population are doing. So in India, we are doing mostly those people who are not eligible for your NOAC, and those who have bled, like subdural hematoma, those who have bled in the GI tract or in the bled in the brain. They're the best people to counsel and to accept. So these are the new devices. You know, these are differences in the height. This is much more safer because you are closing these hooks. These hooks are dangerous, and it can cause these LA appendage perforations by the hooks, and it can cause pericardial effusions. This is different. And this umbilical button is a source for DTR in some people thought. This is also coming down. So this ice sometimes helps. We have done some cases on ice. This DRT, device-related thrombosis, is like a passing weather. It does not mean that all will translate into strokes. They have done some studies putting an angioscope-like device in Japan, Nagamura, and they have demonstrated that these devices is a precursor of thrombosis on the device surface, but sometimes on CT scan, these fabrics or these ovens can be misdiagnosed as DRT. And as I said, the short course of NOAC is important. There are differences in the dimensions, the ease of. So Watchman Flex is just like Amulet, just walk in, and your Watchman is walk out. So that means you go inside the appendage apex and then come out. If you have a thrombus, you can try Watchman Flex, you can try Amulet, you can try Lambre. But if you have a Watchman in your hand and you have a thrombus and you're doubtful whether to put a device or not, you should avoid Watchman Flex because you are going distal. But in other devices like Amulet, SCP, Lambre, and Omega, and Watchman Flex, you are actually making a fishball in the LA and you're going inside. So different sizes are available, maximum, minimum sizes. You can have it from the chart. And these are the things, 12 millimeter or 10 millimeter. So this is nothing new, everybody knows. And these are the animations. And this anatomy is very important to understand. These are all available. The septal puncture is the most important thing. And I will end here. So this appendage is very, very delicate structure. We have 3D model, and you can understand that it is a preventive therapy. You should not produce any stroke to prevent another stroke. So be careful, be concerned about air embolism, not throwing thrombus inside the brain. If you have a thrombus, you can use a filter like Gopal does TAVR on a clarinet, like occluding both the carotids by a filter or a spider, both filter. But once we have thrombus, better to wait for 6 weeks on NOAC. And once we have NOAC, then you can re-examine the TE, and you can always come back with the device. So these appendages different looks. There are different names, fruits names, vegetable names are there, but CT scan may look different. Angiography may look different. TE may give a different looks. The eyes may give a different looks on the same appendage. So the measurement is important. Don't fear about the complexity of the lobes, the angulations. Most of these devices can be fixed by Lambre. 98% can be fixed by Watchman or Watchman Flex. 97% can be fixed by Amulet or SCP. But for all sizes, that newer Lambre device is very, very nice, and we have a lot of experience. With that, I would like to have a comment from Gopal, and thank you, Gopal.
Shed some light. Is it similar to Amulet? I had a look at the device shown to me. I was scared to use it, I must say, so I didn't use it. I'm always scared to use any new device. You know, it takes a lot of.
Lambre beauty is it can have customized sizes. Like if you have OS of the LA is larger than the landing zone. Look, if SCP and Amulet, they have a fixed ratio of your lobe and the disc. But the Lambre have a different sizes. Like if you have a 12 millimeter lobe, you can have 12 plus 6, 18, as well as 24. So if your mouth is wide open, you can have 12 and 24 and 12 and 18. So those kind of choices you have in Lambre. Second, the hooks are different. The chance of embolism also, and ease of use. And it is basically originated from Hong Kong, Dr. Lam. Since because it is not tested and tried in large randomized clinical trial, this is much more acceptable to the community, European community. Forget about the Europe, forget about the US. US will take a lot of time to accept. And second thing, if you have a bilobe, you can put this in one of the smaller lobe, preferable lobe, anterior lobe, rather than coming to the neck. So it is a technically challenging where the Watchman has failed, or the SCP has failed, or Amulet has failed, the Lambre has worked. So it is a new device. I have a very small experience. Ranjan has got experience of 6, 7. I have got experience only 2, and this is much more easy to use.
Because as you very rightly say, this is a treatment that ain't going to get the patient feel any better. And the last thing we want is a complication or a long-term TLR, if you like, some sort of an issue. So as it requires much more care that we don't end up in a problem, I think it's important we have data. Time-tested devices always will stand out, and I hope we'll have some data on Lambre which will give us more confidence. I think that's the bottom line, because when we're doing these things in patients, especially in our country where they're paying out of a pocket majority of the time, it becomes very hard to justify if we have any issues. But maybe I should get you to come and teach me Lambre very soon.
No, the best thing about knowing LA is it's a concomitant procedure. Sometimes somebody who is confident on BMB, they can go to LA closer. Once somebody is confident on LA closer, they can go for mitral clip. Once somebody is comfortable in doing mitral clip, they can go for this mitral annuloplasty or any other procedure on the left side. So it's a kind of, this entry to the left side is much more, comfortable if you already have some experience with LA closer. everybody is not like Gopal, everybody is not trained with TMBR or TAVR. So for the beginners, I would say that many Indians, they know how to puncture the septum. And once you have this kind of ASD device closure knowledge plus BMB knowledge, then you can go to LA closure. Once you have LA closure knowledge, you can always learn mitrectomy very, nicely and easily. And once you have mitrectomy, you become the master. Gopal, can you conclude the session, because I hope
yeah, I think it's been very good just between the chairpersons presenting cases here and there. I certainly learned a lot from Saibal and yourself, so thanks to you both. We don't have any talkers, which leaves us nicely on time, just 10 minutes past our scheduled time. So great to see you, Saibal and Dr. Hazra. Fantastic presentation. Hopefully we'll catch each other somewhere soon. And I'm just sick of these seminars. I hope we'll meet each other in person very soon. Bye-bye.